Okay, thanks everyone for joining. You are at the Transplant ID, Canadian Society of Transplant ID case rounds. My name is Sarah Shalhoub. I'm from Western University on behalf of the CST Transplant ID core group. Today, we're very excited to present Carson Lowe, a clinician affiliated with McMaster University with a focus on infectious diseases and transplant medicine, contributing to the care of immunocompromised patients in multidisciplinary transplant teams. He completed his transplant fellowship in transplant oncology, infectious diseases at UHN, University of Toronto, as well as a master's of clinical education from, medical education from the University of Dundee. As you all know, McMaster is internationally recognized for its leadership in infectious diseases research, innovation, including advances in antimicrobial resistance, vaccinology, and global health initiatives. Carson, welcome. I'll leave the floor to you. So for those who are listening to us over the phone, there's a QR code that Carson would like you to scan for polling questions. Carson?
Great. Thank you for the opportunity to present. The case I've got here is related to a kidney transplant recipient that we saw this year. The title of it is called A Sore Spot. I'm just going to pause for a moment for the QR to be scanned. It will be available again during the polling question, so if you miss, that's fine. So moving on. These are my conflicts of interests, and here are our objectives for today. So I'm just going to start with the case itself, and then I'll ask some questions after. So this is a 64-year-old male who's originally from Lebanon. He received a living donor kidney transplant about 4 months prior, and this happened in Lebanon. Then he came back to Canada for about the 3 months as part of the post-transplant care since. His underlying disease is secondary to a number of potential culprits, including solitary kidney and also diabetes. He then presented to the transplant follow-up with the routine transplant nephrology team. He presented with a 5-day history of a ulcer on the left side tip of his tongue, no prior traumas or triggers, and otherwise doing well. I'll pause here for a moment just to see if anyone has any additional info they'd like to know. And by that, I'm just going to see if by any luck the polling works or not. Sorry, just give me a moment.
Is it Mentimeter?
Yeah, it's Mentimeter, but
Yeah,
may
it
or
didn't
may not
show a
be.
question. It said brand versus generic. I don't think that's
Yeah, that should not be,
yeah.
that should not be the question. So I guess it's not really working right now, unfortunately.
If you have a code, Carson, we can go to menti.com and enter the codes.
Yep, I have the access code. I'll just put it into the group.
Okay, so for the attendees to please go to menti.com, MENT. Yeah, thank you.
Yeah, if it's still showing not the appropriate question, then I think I can just leave it open-ended for the group to maybe just punch in some thoughts of what they think might be questions they'd like to know more about the kind of the history from based on what is already presented, and we can go from there. Apologies that the polling is not going to work, I guess, for today.
I can start with some questions. Is the recipient on any herpes simplex prophylaxis or CMV prophylaxis, and what are their donor and recipient EBV serostatus?
Great. So I'll give you all of that afterwards. But in brief, yes, has been on antiviral prophylaxis. ATG received as part of the induction. So Sarah asked some questions as well. Similar ulcers, genital ulcers, none prior. And then the brand versus generic, sorry, yeah, that was the other question earlier. Just going to flip forward here on the slides because I don't think I'm going to be able to. Here's some of the information that I think the group might want to know a bit more. So for the individual for pre-transplant, otherwise the patient has had an unremarkable kind of pre-transplant workup and also phase, has not had any other similar episodes of any genital or mucosal lesions in the past, no prior history of any recurrent infections, has had a TB skin test that was also negative, no known exposures. The donor, with the limited information that we are provided, is a stepbrother apparently, and no known infections of the individual. And the individual was doing well both pre and also post donor surgery. And then this is the transplant history of the individual, as we set the underlying disease as listed. ATG as the induction, R positive for both the CMV and EBV, has been on valganciclovir prophylaxis with good compliance. And here are the triple immunosuppression that the individual is on, which is standard in this case. So I'll move on to the next slide. This is the past medical history of the individual, which I have listed here. There does include a history of a gunshot wound to the face in the past with a bullet still in place, but actually it's not the same location and has been stable for a large number of years already without any interventions or any issues related to that. On the background, the individual was born in Lebanon, has traveled quite frequently back and forth, also served in the army before as well. He previously worked as a vinyl worker as well. No other known exposures that are of note. Those are his medications before transplant and also post afterwards as well, in addition to the immunosuppression and prophylaxis that I have listed here. So when we first saw him, or rather my transplant nephrology colleagues had seen him, they had started him on some empiric therapies for wondering about what the diagnosis might be. He was on valganciclovir prophylaxis, as we mentioned earlier, but the dose had been increased to empiric therapy for possible either CMV versus HSV VZV while waiting for the swabs at the time, so went to 900 BID. The dose of the myfortic was reduced a bit, and he was also on triamcinolone TID as well, along with nystatin mouthwashes. The initial swabs that were done, those were the HSV VZV PCR from the tip of the tongue, was negative on the initial assessment. Unfortunately, about 14 or 2 weeks later, the lesion continued to progress, increased to quite a large size, at least 2 by 3 centimeters, then continued to get bigger. And it was associated with quite a lot of pain. There was also a new lesion that began to develop on the right side of the tongue. He did, for what you have it, a empiric course of oral antibiotics that was prescribed to him by his transplant nephrology team, and a repeat swabs on the tongue once again was negative for the HSV VZV PCR, and then the blood plasma for EBV CMV were negative. He did unfortunately develop some leukopenia with the dosing from the valganciclovir, and in light of the negative results, was put back on prophylactic dosing, given also the no improvement with the current therapy. He was then referred to us at about 18 days from the presentation, and this is how the lesion looked like on the left side of the tongue, with a worsening size and depth of the lesion. By the time he did see us, he was also actually referred to an ENT who performed a biopsy and also performed a nasopharyngeal laryngoscopy of the individual, because he did also present with some kind of sinuses and also discomfort and difficulty swallowing. They had found no other lesions elsewhere besides the 2 that we mentioned about on the tongue thus far. At the time of the assessment, the biopsy was pending on the pathology, and then we had asked for some infectious workup along the way. Wondering about, unfortunately, with the polling, that doesn't work. I'm going to leave this at the slide at this moment to see if anyone has any thoughts of what differential diagnoses or potential diagnoses this might be that they're wondering about. or maybe never mind, I guess it's working now. I'll give it a minute or two more. Just going to mention in the chat group also some questions about query NTM versus TB versus histo versus toxo as well, and then some questions of exposures to goats and sheep. I will clarify that there were no exposures to goats or sheep or any unpasteurized milk that I'm aware of from the patient. Great, so I'll move on. So a nice little distribution between TB versus NTM, which I forgot to write there, sorry. Endemic mycoses, leishmania. So I'll move on just to give some more information. So from the differential, here are some of the ones that we had when we first assessed the individual for infectious causes. Certainly, of course, those may include viral reactivations. Even though the swab had been negative, we had actually seen a couple of cases before where the swab itself, despite it being in this case a mucosa lesion where we expect the sensitivity to be quite good, we have had a few where actually there was a discordance between the swab versus a tissue diagnosis ultimately. So we were waiting for the repeat biopsy from ENT and then asking for PCRs from their fourth. Other things to consider as well, of course, includes EBV or PTLD, although this is somewhat a little bit early in this stage of the presentation. HHV8 was also within the differential. However, patient has no other additional new sexual exposures. And then endemic mycoses. Also parasitic in light of the individual with a history of frequent travel to Lebanon as well was also in question as well. And we'll discuss a little bit of that kind of differential and where and when we might want to think about some of these diagnoses. But also at the same time, it was important to think about some of the non-infectious etiologies as well. Those include things like drug-induced reactions, including to CNIs, mycophenolate, which have been well documented as well. mTOR, which is not relevant in this patient's case, as well as some other non-drug induced or non-infectious related etiologies of the oral ulcers as well. Those may include like GVHD, aphthous ulcers, and other undiagnosed autoimmune conditions, which at least from this patient's history is not known to this date. So we'll just go over a couple of maybe to highlight some of these important infectious syndromes and also how it may be quite difficult to sometimes actually diagnose some of these without a diagnosis by biopsy or by further PCR testing. Clinically alone, it's actually quite hard to sometimes differentiate between them. Even though these are some of the images that I'm showing here, to be honest, from a literature search and also from experiences through myself and my colleagues, there is a wide ranging of presentations that each of these lesions may present as. But as some examples, on the top left, you can see an example of a CMV ulcer of the tongue that's affected in an individual who is a non-transplant patient, but those who have been exposed to steroids with an underlying history of MPA. Whereas on the other hand, on the top right, you've got lesions that are either sometimes more exophytic, as opposed to the one that looked more like an ulcer on the top left earlier from CMV, with HHV8 and Kaposi sarcoma in a patient, for example, such as those presenting with AIDS. You may expect to see some more violaceous or dark red exophytic enlargements of the palate or gingiva that might be indicative of that diagnosis. Certainly PTLD is always within, or EBV-associated PTLD is always within the differential in the right context. Although this individual, I mean, it is sort of within kind of the period of around less than a year or within the first year of the post-transplant. Within the differential certainly may include EBV-associated PTLD, and of course will require a biopsy and EBER protocol to also further kind of delineate whether or not this is, and that's an example you can see here on the bottom left from pancreas transplant recipient. And likewise, although much less commonly, other viral entities that we didn't mention from reactivations, but rather primary infections by enterovirus, rhinoenterovirus or Coxsackie viruses, although more commonly seen in pediatrics, may sometimes be important to be of consideration too. But in this individual's case, at least, there were no other lesions besides those on the tongue. It doesn't necessarily mean that it isn't, but certainly would be something to kind of look for during the clinical assessment. Outside of viral, of course, we include some of the other bacterial or atypical or uncommon bacterial infections, those of which includes NTM and TB. Here's just some examples of the wide variety of how TB lesions may present as in immunocompromised individuals. And those may include anything from nodular-like lesions to papular-looking or ulcerating lesions of anywhere between the mucosa, gingiva, or the tongue itself. Often they may occur in areas of where the trauma had occurred, but again, these are very non-specific findings of the actual lesions that you can see from the mucosa, and again, further emphasizes the need to have to take a tissue sample of some form and have it sent off, including for TB cultures in these cases where they are highly suspected. In our case, in our patient, for what it's worth, at least the latent TB workup was negative, and there had not been any other manifestations of TB of the individual that were indicative, besides the presenting oral lesion alone. And oral TB lesion, again, as an isolated manifestation, is quite uncommon per se, but still on the tongue may still be one of the potential manifestations per se. Going on to some other lesions, again, to just illustrate or visually illustrate some of the what may look like among these endemic mycoses, those of which on the bottom here, including histoplasma and blastomyces, you can see a wide variety of those that may involve either the hard or soft palates, the gingivas themselves, or the oral mucosa, in a wide variety of different ways of manifestations. These often present either due to a inadvertent local inoculation versus a hematogenous dissemination, in which case, of course, if the differential includes endemic mycosis, one must, of course, be hunting for other areas of dissemination or involvement, including imaging the sinuses or imaging the pulmonary or CT chest at the minimum to look for other manifestations or presentations. Among fungal pathogens, certainly still Candida remains the most common. At least in our patient's case, they had been exposed to or was given an empiric course of nystatin without improvement for what it's worth. But just to illustrate kind of which types of variety of presentations that this may present as for the individual. Mucorales sometimes may present in this kind of scenario too. Certainly, we have seen a variety of some of these manifestations during the COVID pandemic and the time where patients have been exposed to steroids as part of their COVID management and treatment. The presentation often is a lot more rapidly progressive, maybe perhaps as opposed to some of the other manifestations and differentials we just mentioned, especially in the other compared to the other fungal organisms. Oftentimes they do involve the either oral or hard or soft palate of the individual, and definitely there's always the concern of it with tissue invasion to move towards the maxillary sinuses. And again, similar to the other discussion earlier about endemic mycoses, it's very important to also hunt for either other sinopulmonary or GI manifestations of the syndrome, and to be hunting for those through further investigations or imaging where appropriate, or even if scope if necessary. Symptoms are often very nonspecific, unfortunately, across most of these manifestations that we've just talked about. And those include the atypical presentations of including mucorales with facial pain, sinus pains, or odontalgia. But they're not specific towards just the diagnosis of mucorales, and certainly may be symptoms that you can expect from the other differentials that we had just discussed or just looked over in a moment ago. I briefly want to just bring up leishmania because of the individual in this case coming from Lebanon. I think it's important to just highlight that not all cases of leishmania necessarily will manifest in the mucosal involvement. More commonly, we do expect to see these from the New World strain with the Leishmania brasiliensis viennea. But from the Old World, there is still possibly, if it comes from the Leishmania infantum, that there is a potential for the manifestations of mucosal involvement, such as those that are illustrated from here with the exophytic or fleshy swellings of the mucosa or lip or gums of the mouth. They are by far not that common, though, at least from when I looked through on the kind of what the prevalence is through in Lebanon. By far the most common still remains to be the cutaneous Old World Leishmania that is described, and much less so the Leishmania infantum and Donovani are much lower in terms of the rates of infections in the region. But just something to kind of highlight. Certainly it needs to be investigated or needs to be kind of further looked into. And often the manifestation, if present, you would also then, of course, be looking for risk of hematogenous or lymphatic spread or dissemination, and to be, again, looking for other clinical manifestations to be investigating this for. Just going back to that differential we had earlier with both the infectious and also the non-infectious causes, and just to put some of our patients' context into the picture, certainly it doesn't mean that we have officially ruled out the diagnoses, but just some things for food for thought. So the individual had been exposed to, at first, Valgan cyclovir prophylaxis, then later on to treatment dose, of which the patient had no response to the therapies and also had negative PCRs, at least from a swab for what it's worth. CMV, EBV, blood or plasma's PCR had been negative, which also puts that into the context of while working out with the differential. No new sexual exposures, and had a negative TST and also negative pre-transplant syphilis, which was among things to consider as well, and as well as the HHV8. And then the patient had, besides Lebanon, has not traveled to anywhere else, specifically not to Latin America and other parts of the world. It's just Lebanon and Canada only. On the right side here, I put down some of the other medications that the patient's on. Those include their immunosuppressives. Those are the Advigraph and the Myfortic here specifically. Something just to also think about as well. Highlighted in red were, of course, among the differentials that we were most worried or concerned about. And I think those were kind of reflected from the polling that was just had earlier as well, including the Leishmania. So what happened was then the pathology came back from the ENT sampling. It was a bit non-specific, at least from the histopathology H&E stains that were mixed inflammation, fibrosis, and edema that was seen. I don't have the slide pictures, unfortunately, to show, but there was no concerns of any evidence of lymphoma or PTLD that was seen. Immunohistochemistry for some of the herpes viruses were also negative. The pathologist did also perform some stains, those as listed, that were all negative. Unfortunately, when ENT performed the sample, there were no tissue cultures sent for any form or way to microbiology, and all of them were done just isolated to just the pathology. So going back to the workup that we had, certainly a large number of them on the left-hand side we would like to perform. One way we could have approached this was to perform the PCR testing from the histopath, but going by which, because the patient's history in terms of his clinical timeline, continued to worsen by each day following from the biopsy that had occurred, and with worsening difficulty to eat. He was ultimately admitted. He did have some pains over his sinuses at the time of presentation that we were not sure and was a bit non-specific, and so we asked for a CT head at the time to rule out for invasive fungal infections and started him on IV liposomal amphotericin B as well, empirically at the interim. His immunosuppressants, because of this possibility of infection, was also held, including the Myfortic, and the prednisone was adjusted. And that was his presentation on the time of admission with the lesion on the right-hand side. So among the workup, because of this presentation and rapid progression, despite some initial management, we did ask for an expedited biopsy, both for which of histopathology as well as to microbiology. And on the left here were all the tests that we had asked for. Some of which I may have missed accidentally, sorry, but the majority of which, as you'll see here, including for herpes viruses, this included for tissue for CMV as well, enterovirus as well, had all been negative, including HHV8. Cultures were non-specific. It was just mixed aerobic organisms as expected from oral flora. A repeat syphilis serology was also done, fungal cultures and also TB cultures. Of course, certainly not all the results were back at that moment, but the preliminary at the time was no AFB seen and no fungal elements seen. I believe I may have asked for a TB PCR for what it's worth, but regardless, that was also negative. We did have a histo and blasto serologies that were done. For some odd reason, the histoplasma serology got canceled or was said that it was inappropriately done. I don't understand what that means. But blasto was there, non-reactive, crypto-negative, and also a Leishmania serology that was also negative. This was the pathology that came back about a week or two afterwards, and somewhat similar to the prior initial biopsy that was performed. Again, diffuse ulcerations and inflammations were seen. Some rare fungal hyphae were seen along with yeast and bacteria, but it was thought to be more of regular oral flora that was discussed in correlation with the cultures that had came back ultimately. Those were the immunohistochemistry and special stains that were also requested for, all of which had been negative here. Interestingly, though, so after the third day of admission, now day 21 from the presentation, the patient actually started to improve in terms of the lesions. But just so you know, in terms of the timeline of how long he'd been on the amphotericin B, he really only got about one dose maximum, because actually his creatinine rose quite a lot, also probably in the context of not eating and drinking too much, and the AKI transiently, probably also pre-renal in nature. And so then the transplant nephrology team had stopped the amphotericin B at the time. But by day 2 and 3, his lesions actually stopped increasing and worsening in size and started to improve. There was a bit of concern of that he, because of his early post-transplant stage, that he still may have needed a little bit more immunosuppression. So then a bit of steroids was given by the transplant team, and he continued to actually improve clinically. And this is actually the timeline of the remainder of the photos that I have for his lesion. In the middle of the one was the last one that I just showed you, where the lesion had worsened enough that he needed admission in a brief course of amphotericin B, or rather a single dose of exposure. But subsequently, within the hospitalization up to day 26, the lesion actually started to recover almost completely. And then by the time we saw him in outpatient, his tongue lesion had almost actually completely recovered. It's a little bit hard to perhaps appreciate on this picture alone, because we didn't show all the angles of the photo. But the lesion, of which not just the large one that we're focused here, but he had actually multiple other lesions on the right side of his tongue that goes towards the back of his tongue, at least 2 to 3 additional ones. Those have all also healed as well in the process of all this going on. As you'll notice that the timeline of some of his immunosuppressives, his prednisone I did not include here, which was just baseline after the methylpred was given briefly. But the mycophenolate sodium or myfortic had stopped by the time of admission after having been reduced initially from initial assessment, and the tacrolimus continued at more or less the standard dosing. So I'm just going to briefly touch upon, I think, what we believe to be the most likely diagnosis here based on the process of elimination from all the workup that had happened, both from histopathology and cultures, is we believe that actually it may potentially be related to myfortic, which had been stopped during admission, and subsequently the patient started to recover. As a reminder, myfortic or mycophenolate sodium is the reversible inhibitor of the inosine monophosphate dehydrogenase. And this one's responsible for, as part of the cell cycle inhibition, that's part of the transplant immunosuppressive medications that are taken. Because usually like the T and B lymphocytes are quite dependent on this proliferation cycle, this effect of the medication is meant to try and act as a very potent cytostatic effect on those lymphocytes and prevent the risk of rejection. There are multiple formulations of mycophenolate. Those include the myfortic mycophenolate sodium, but also CellCept with mycophenolate mofetil, which I have the examples on the right. Among those side effects that can be expected, certainly the most common ones being diarrhea, abdominal pain, or GI symptoms. But among the other ones as well, it actually may include potentially oral ulcerations or tongue ulcerations as well. There has been a number of reports since as early as, from what I can find, 2001 perhaps. Most commonly, the reports have been associated with CellCept or the MMF at least. Other drugs that may also be involved, of course, because these patients are often on multiple immunosuppressives, may include mTOR inhibitors as well, which are more common for causes of ulcerations. But MMF and myfortic certainly are among those of which to consider within your differential once you have ruled out other infectious etiologies of the presentation of the oral ulcerations. Usually the timing of when it can occur is a little bit variable from the literature that I can see. It could be anywhere from within weeks of being exposed to the medication, upwards to a few years from being on the medication. Generally, though, once you've stopped the medication, once you've stopped the medication, the lesion actually stops progressing within 3 to 4 days, which is kind of similar to our patient's timeline. And usually about a week or two from here, the lesion actually will start to be completely resolved or start to heal completely overall. Some of the pictures on the right here just to illustrate kind of the varying different presentations of how the lesion can look like, but quite non-specific and really honestly quite hard to say without a tissue diagnosis to confirm any other etiologies before assuming this as a diagnosis of exclusion. This was the literature of which I was trying to illustrate earlier or trying to discuss, that lesions may occur from any time from as early as within a week or within a few days of starting the medication, upwards to even a few years of being on the medication despite being on stable doses. Most of these lesions, as you can see on the right-hand side here, begin to heal within a week or so, and shortly after, with adjustments of the immunosuppressives, stabilize and improve. The additional twist to the whole story, though, which is kind of interesting, I want to open this up to discussion as I conclude my presentation shortly, is actually the patient when we saw him in the inpatient hospitalization. He actually mentioned, in fact, he was not being given or was not taking Myfortic per se, but was given quote unquote a different medication, which we weren't really sure at first what he meant by that. We had to call the pharmacy, and turns out that actually he was just being given the generic form of the mycophenolate sodium, or in this case, mycophenolate acid. But my question to the group, and shortly to conclude the presentation, is, does this matter or not? Or like, do we care or not care about this? And wonder if poll works or not this time. Okay, so some mixed responses. Yes, a little bit of yeses, but mainly no's and I don't knows. And I was also really not sure, to be honest, too, at first when the patient brought this up, but it was kind of an interesting point. Certainly, we've never re-challenged him with Myfortic or the mycophenolate sodium trade. At this point, he was very reluctant to take it ever again, or any mycophenolate for what you have it. But when I tried to look at some of just the breakdown of the constituents of each of these drugs, they're more like, I mean, the active component is basically the same. The only part that's a little bit different may come from the excipients and then also the enteric coating formulation of each of these drugs. For what it's worth, I would say when I looked through each of both the excipients and also the enteric coatings, not many of which had been highlighted or described as any issues. The one I highlighted in red, which is the SLS, or sodium lauryl sulfate, is the only one that apparently, when you look at through the literature, may or may not have some signal towards potentially oral ulcerations or associations with it. And the reason why I'm just bringing it up out of interest here is it's commonly found in some specific toothpastes, but a lot of times some toothpaste themselves will say that they don't contain any SLS specifically, and the reason why they say that is apparently through at least systematic reviews that have done comparing about 101 patients through RCTs. Patients that have been using toothpaste that contain SLS appear to have or suffered from more frequent ulcerations. Um, for what you have it's the recurrent aphthous stomatitis that they're describing here. But that's just something kind of just food for thought, a little bit interesting. Certainly more studies are still needed to actually look at the associations between SLS and recurrent aphthous stomatitis. And I can't say necessarily that our patient has this problem because of this medication per se. He's never really been challenged with the Myfortic long enough to have compared between the two drugs, and certainly not having or not wanting to be re-exposed to the trade drug either. It's kind of hard to know really at this point, but just something interesting to kind of bring up to the group. These are kind of just my final thoughts or just kind of messages through the case from today. So our diagnosis at this time, based on diagnosis of exclusion from all other infectious causes or also other malignant causes, is we believe this to be an oral ulcerations, probably aphthous-like in nature and perhaps associated with mycophenolic acid-associated mucosal toxicities. It's a probable diagnosis. I don't really officially have a proof of it, but it is diagnosis of exclusion based on the timeline, the improvement that the patient had from stopping the mycophenolate as well, and no other clear other diagnoses that were present, but happy to discuss this further. Certainly always a tissue biopsy, including both for cultures and microbiology, are very important to help with getting towards a diagnosis. When needed and when necessary, certainly empiric antimicrobials, including antifungals, if the correct compatible symptoms should always be considered as well. So that ends my presentation, and I'm happy to answer questions or open the floor to further discussion about this. And thank you for the opportunity.
Very interesting and frustrating, that piece of sending to path but not to micro is just so painfully.
Always, yeah.
did you mention anything about the role of running? I don't know what your experience is with running like a 16S RNA or ITS on tissue samples. Our experience has not been impressive, I have to say. Out of like 30 samples, we only get one potentially meaningful result, and so I'd be interested to know what you think or
Yeah,
what your experience
I
is.
think it also, and I'll open the floor to any other thoughts that other people have too. But from my experiences, I guess it's always been very dependent on the tissue sample that we're taking. And I felt maybe perhaps if this case got a lot more complicated, where maybe they did not improve with stopping or holding the mycophenolate, and then things progress and not improve despite on empiric therapy, I definitely would probably consider pursuing. I guess it gets challenging because when it comes to the type or nature of tissue like this one, where it's an oral tongue tissue biopsy and already having a bunch of mixed aerobic organisms, I'm not sure whether or not the signals that I'm going to see are actually true signals or they're just a bunch of noise, or if I'm even going to pick up anything of clinical significance that would alter the way I would have managed the case. So I think this one's a bit tougher, but if maybe it was a different sterile tissue, I certainly would push a lot more, despite, as you said, many times that where we end up having still nothing from the 16S PCR, which I agree it gets a little frustrating sometimes because we depend on it quite a lot in a number of the very relevant scenarios, but certainly it gets a little tricky.
Yeah, yours is definitely more challenging because it's not sterile tissue, but yeah, interesting case nonetheless. And did you mention anything? Was there anything on the sinus imaging? He kept complaining.
Right. Sorry, I forgot to mention. So because, yeah, during his admission and when he had this kind of really concerning or alarming sinus symptoms that really pushed the start of the amphotericin, ultimately the sinuses showed nothing. And ENT, who did the repeat biopsy, much to much to their dismay, because we were the ones that asked them to perform the biopsy, and it was like a second or third attempt when they finally actually sent cultures out, and even then there were some issues. They performed a nasopharyngeal, like a repeat scope all the way through and looked around, and it was completely clear. Nothing was seen in the CT. I forgot if we did an MR as well, but none of them showed anything of prominence. No eye involvement, no sinus involvement. Bony tissues were completely like fine. It was just the swelling on the tongue alone. And then likewise, I think the imaging did look down to the neck as well too with CTs, and it didn't show any like esophageal thickening or something else that was going on too.
Mhm. Yeah, the case is interesting because I never really thought of the other component. We have seen quite a few mycophenolate triggered mucosal ulceration, and usually we get pushback because it happens early on post-transplant, and the transplanters are usually quite uncomfortable stopping mycophenolate early after transplant because of the risk of rejection. But yeah, it's not uncommon. But that
Yeah, this one was a big struggle. If this one took basically the 3 weeks of the whole presentation before they're finally willing to completely stop it. It took a while. Like they were more comfortable weaning the dose, but as you said, to ask them to completely stop the drug, they also don't have a lot of history because he performed the transplant outside of Canada with a very limited kind of information to work on. They were quite hesitant, so that's why they ended up trying to compensate and added some more steroids afterwards too, ultimately, for what you have it.
yeah, I'd never found tapering or reducing like mycophenolate doses to be helpful. It's often
Yeah,
discontinuing altogether. Yeah.
exactly.
Anyone has any questions? Got it.
I'm just going to share, we have similar experience. Like we've had patients admitted to the hospital unable to eat with significant weight loss due to severe ulceration, and it's stopping that actually helps resolve thing. We as Transplant ID don't tend to follow them along, so I don't know if eventually they're restarted on a low dose within like after the first year and if they tolerate it. So I'm not sure if anyone has had any cases where they've been restarted. After their first year and they've tolerated it.
That's a good point. I don't think the ones we've seen were ever restarted because the patients know it's the mycophenolate that triggered this, but yeah, it's worth looking into for sure. We've got Andrew and
Yeah.
Sasan. Yeah.
Carson, great talk. Really always enjoy your presentations. So like these always have to be managed essentially as diagnoses of exclusions, which means that people are, subject to the toxicity for long periods of time. I'm just wondering, is there any other like biochemical correlates of this toxicity, something that we would be able to investigate earlier or implicate it rather than essentially spend all this time trying to do all this other micro that often takes 1 to 2 weeks in
Yeah.
order to try and rule other things out?
I I wish I have an answer. I don't think I have one, Andrew. Sorry. At least from what I looked at, I don't think I found anything worthy of mention that kind of looked at indicators or interesting either whether it's a clinical clue or a biochemical clue that helps to push towards one of these diagnoses. And exactly as you said, the most frustrating part about each of these is the logistics of trying to like you try to not admit these patients when they're not severe enough, but then coordinating all these tests that are done, half of which gets done, the other half doesn't get done. And then and then you're chasing for the results, trying to figure out where the samples even went to. And then ultimately, some of these tests, of course, just naturally takes weeks or turnaround times are slow, and you have to ask for a lot of approvals from different departments to proceed. And even then, you're not necessarily going to get a very satisfying answer. And as you said, it's ultimately unfortunate at this point, to my knowledge, is a diagnosis of exclusion where you just have to at some point talk to the team and say, like, the drug needs to stop, which kind of happened in this case. It just took a lot of talking. Like, I think I talked with two or three separate both MRPs, like the outpatient MRP, the inpatient MRP, and it took several talks before everyone was comfortable finally in taking that risk, understanding that I have no other, like I tried empiric start of antimicrobials, didn't do anything, both outpatient and inpatient, and I think we finally came to terms. It just takes a lot of time.
For sure. Sasan?
Thank you so much, Carson. This was a great talk, as always, comprehensive, and you reviewed differential diagnosis very well. Um, did you guys think about aphthous lesions? The reason I'm asking is that transplant itself increases the risk of aphthous lesions, and also some transplant medications on the top is mTOR inhibitors, and then MMF also may cause aphthous lesions. Did you guys consider this is also differential? I mean, diagnosis of exclusion, so we need to rule out other diagnoses first.
Absolutely. Like that was the trickiest part, Cezanne, when we went through this case, which I'll see if I can go back to that slide I had. But because the differential is just so broad and includes a little bit of anything is possible, while I was waiting for the majority of the like besides some of the PCR tests that came back first for the infectious etiologies, but for the drug-induced ones, in this case, the patient being on Advograph and Myfortic, and as you said, even just in general with transplant-related aphthous ulcerations may also be a diagnosis to consider. I guess I was just picking between which of the two drugs, in this case, between the Advograph and Myfortic, that the team was willing to let me make modulations of. And I think part of the reason why I was able to push for the Myfortic to get stopped first was because they were up front, they were worried about infections, and I guess they felt more comfortable completely holding the Myfortic and see what happens. And that just happened to be what worked well in this case. But it could have easily been the other way. It could have been that we stopped the Myfortic, kept them on ambisome, and nothing improves, then I'm stuck. Like I think it would be quite challenging to say like, should we resume the Myfortic? But then we don't have all the results back. But then what are we going to do about the tacrolimus? Like you're going to try something else, but what is the something else, I suppose?
Yeah, exactly. The problem with aphthous is that it is recurrent problem.
Yeah.
So when you stop that again, it may come back again. I had similar patient and it was a challenge.
Yeah. This one, I think we lucked out that it just stopped and then it never came back. And of course, he never wants to be back on the drug. And that's the current, like he's now several months out and he's very happy and he's everything is fine now.
Perfect. Thank you.
I don't know if there's been a comparison. I don't think there is one, but anecdotally, we've seen a lot more MMF-induced mucosal ulcerations than I have due to CNIs. So yeah, I guess that would be the way to go first, probably.
Yeah.
Okay, very good. Any other questions?